So greeting everyone. How are you doing? My name is Ewan Affleck, and we're very...
Ewan, we're not able to hear you.
You are not able to hear me. I am unmuted. Can people unhear me? Can people unhear me? You can hear me. Okay. So thank you very much. Hopefully everyone can hear me. So Stephen, maybe you can mute yourself now, and David for the time being. So greetings, everyone. Welcome to the second Network Health webinar. And today we will be examining Bill C-72 and everything about Bill C-72. And just a little bit about Network Health before we get going. So we are a nonpartisan, sort of apolitical collective of individuals who are passionate about improving the design and use of health data in Canada. And so we are involved there. We have members from across the country. We have 3 chapters. It started in Alberta. And now we have a BC chapter, and we also have a chapter that is just getting going in Ontario. And so we're involved in projects collaboratively on a whole variety of things. And our very first report that came out focused on interoperability. And our very first recommendation, and it was called Interoperability Saves Lives, our very first recommendation in our first report suggested that interoperability should be legislated in Canada. So shortly after that, Bill C-72 was introduced. And I'll just move the slide ahead here. So that's what we're focusing on today. And I just need to tell you a little bit about Bill C-72, and then I'll introduce David and Stephen. But this refers to our campaign to reintroduce Bill C-72. And later you'll see a QR code here, so you can go to our website and see that. And we have many organizations who are supporting this. I think we're now at about 39, and this has been live a little over 2.5 weeks, I think. And from the Canadian Nurses Association, the Canadian Medical Association, Digital Health Canada, Converge, the College of Family Physicians of Canada, and Innovate, and many tech vendors and patient advocacy groups like PAN and Greg's Wings and Imagine Citizens and so forth. So we cover a wide scope of organizations. So just a little bit about Bill C-72 to set the context today. So this is a bill that unfortunately died on the floor, as it is because Parliament was prorogued for the last election. But it was introduced, and the first reading was on June 6th, 2024. And it's a very short document. The actual body of it is 5 pages long. The intent was to introduce the legislation. It's largely unblocking legislation to ensure that data flows between different technology platforms that hold health information. That really was the focus of it. unfortunately, for procedural reasons, as I said, it died. It was unable to go through the 3 readings that are required for something to pass then to the Senate and to become an act. So we'll talk about Bill C-72 today, all things Bill C-72. We've received quite a few questions. And so I just want to introduce the 2 guests here. You already heard Stephen a little as we get going. And this will be informal. So we have with us two fabulous guys who I work with and respect deeply. I couldn't find 2 better people, better suited to discuss this. They're both sort of policy wonks, as it were. David, who you see there on the screen, is a professor at the Department of Public Administration and Business at the University of Victoria. He's a philosopher and a bioethicist, and really a polymath, and has many titles and roles, too many to relate at this point in time, but he is deeply involved in the whole data discourse in Canada at many levels. And I worked with David on the expert advisory group, the Pan-Canadian Health Data Strategy, where he provided very important insights to the rest of us. And Stephen is a lawyer, and he is a partner at INQ or Inc. Law, and probably one of the leading health data law experts in Canada. And he's the co-principal author of 2 of Network Health's reports, Disconnected Care and Data Disarray. So welcome to both of you. I don't know if you want to add anything about who you are, David or Stephen.
That's a great introduction. Thanks, Ewan. I'll probably just say that I've been with Inc. for a couple of years, but prior to that, I was with Vancouver Coastal Health for many years. So I have many years of lived experience with health data sharing and its impact on the healthcare system through that.
I think the only thing I'd add is, first, I'm not a bioethicist, but I can tell who's looked at my Wikipedia page because it's the only publicly facing reference to me being a bioethicist. So I think that's pretty funny. I'm actually a science, technology, and innovation policy person. And I work in the School of Public Admin at UVic. But I'm also, right now I'm in Ottawa because I also do work for the Chief Science Advisor to the Prime Minister, which I've done for almost 4.5 years anyway. And one of the major things that we've undertaken within Dr. Mona Niemer's office is to think about bigger picture issues around data governance in Canada. And we released a report, I guess it was late September, early October, which is on the Chief Science Advisor's website, which is just about a data governance framework to take the generalized problem of data governance seriously. And so I took one step back in generality to work on that report for Dr. Niemer. But everything that we said in there is supportive of and provides an architecture as well for thinking about what we're going to say in the health data context as well. So, the kind of work that the 3 of us are doing is like kind of laying bricks on top of one another to build a real structure around this. And I think it's super interesting work. So that's a bit more about me.
Excellent. Yes, I did grab that. So you have to change your Wikipedia. I don't know where I saw that, but it's somewhere. And I know you, David. Thought I'd be pretty official about it all. The other thing I want to say about the 2 of you is you're both members of the coordinating body of Network Health British Columbia. So you've been involved in our growing network, and really I think we feel collectively that together we can make Canada a better place, as sort of altruistic as that sounds, through improving health data. So I'm gonna we asked for questions, and there were many questions submitted to us, some really actually good questions. And people can also add questions in, and Terry Price, who's behind the scenes, will navigate those, and we'll try to answer as many as possible. Given the number we've already received, I don't think we'll get through them all, but and we'll have this hopefully broad informal discussion about that. I've suggested to Stephen and David that we all interrupt each other and interject and so forth. So please feel welcome to do so. So the first thing I'm going to get it all started, someone asked why we can't see, and I'm reading this, a coherent plan between all levels of government, federal, provincial, territorial, municipal, to work together on health and health outcomes. What's holding us back? And presumably this means around some data strategy or legislative framework. And they point to why some European countries are able to do this. So I'll throw this out to you guys if you want to start. Stephen, you want to go first, or David?
Sure. I think this was a topic that we covered in the data disarray report that we produced, right? We asked the question, who's in charge of health data design and use in Canada? And we found that really no one's in charge, right? We found that historically there's been, a lot of legislation and laws geared towards data protection, which is understandable, right? Whatever it was, 25 years ago or so, we started on the path of electronic health records, and it became a lot easier to share data. So there was this, I think, assumption that, that was going to be the easy part, right? The flow of data, and that we needed those privacy and security safeguards. So the heavy focus on privacy and data protection legislation. But I think what has happened is that because of the way that it was designed around a custodianship model, which focuses on data protection, it's led to a bias towards that type of behavior and parties sort of being very risk averse when it comes to data sharing. So, so as a result, it's sort of unfolded in the way that it has, and there hasn't been really, a big overarching strategy, I would say. And I think a lot has to do with the fact that there's probably not sufficient data literacy within the health sector to really appreciate the significance of how much we need to actually plan for how we govern and manage data to improve the system.
So David, do you agree, or do you want to add to that?
Yeah, I would agree with that, and I appreciate the fact that Stephen raised the custodian model. I think we're going to talk a lot about this more, about the what alternatives there are, but certainly the way that privacy protections have been introduced. Some of them generic, some of them specific around health data, some of them provincial, some of them federal. We might actually have privacy legislation overkill relative to the problem of managing health data. So this feeling of disproportionality, I think, is something that we experience when we look at what's really going on. I suppose the other thing I will say about this is that the question is why don't we have everything kind of in line in Canada and nicely organized? And it's I would start where Stephen started as well, which is what's the locus of control, and the local locus of control is in the provinces and territories. So if you've got a bunch of different jurisdictions, each with the essentially the sole responsibility for this under the Constitution, with some minor exceptions, but basically sole responsibility. It's like having 13 houses in a row and expecting everybody going to decorate them in the same way just because they live in the same neighborhood. It doesn't work that way. I mean, they all have different pathways and histories, and even provincial cultural matters to attend to, and it just means that there's a myriad of drivers within each province and territories for that make them be idiosyncratic relative to one another. They don't share the same sort of evolutionary story that would drive them to look all the same. And so I think this is just a causal kind of artifact of our confederation, and it's what happens when you devolve powers to lower levels of jurisdiction. They tend to do different things, not similar things.
Yeah. So fascinating. So, and this person in this question refers to what they've done in Europe. I mean, these are different countries that are now coalescing around common standards. Yes. We seem to struggle to do this in the same country. My question So, David, you talk about, and this is where Bill C-72 comes in. If indeed data oversight was devolved to the provinces, then presumably the federal government couldn't introduce federal data legislation. They'd be infringing, but they did, right? So, Stephen, as the lawyer, does that mean, so who actually has oversight of health data?
I think, yeah, it's not clear because there is a division of powers when it comes to healthcare, right, between federal government and the provinces. So I think, as you know, there are certain provisions in the Canada Health Act, in terms of its aims, including portability of care, right? So it can certainly legislate in that realm and tie data, the flow of data to follow patients to that principle. But yeah, I think, it's not, I think there's just more of a lack of attention as opposed to like a jurisdictional battle, in my view, right? I think one of the things that we looked at in the reports was, I think was really new to me, was tying this whole health information policy to the Canada Health Act, right? Which really hasn't been done. I think that's a gap, because if you think of health information policy as really part of health policy overall, then you would switch your mindset to say, we do have a Canada Health Act, the federal, government and Health Canada, want certain standards to be in place, consistent across the country. So similarly, then you can sort of have that line of thinking in terms of health data as well, right? Health data governance.
Interesting. So, and then there's the whole question. So if we do things 13 different ways, like you've said, David, and there's also Indigenous governance, so maybe 14 different ways, or there's 3 Indigenous. So my math is failing me. 16 different ways, and then the federal government 17 different. Anyway, lots of different ways. Does this serve anyone? Like who benefits from this? Do Canadians? Do governments? Is this not a highly inefficient way to do things? Even if they do have the oversight, even if it is conferred upon provinces and territories, does this not make sense for them to work together?
Well, that's an interesting question, because arguably when say a province is managing health data within jurisdiction, and were it to be doing it effectively and efficiently, they might say, well, this is ours to work on, as provinces often assert, and it wouldn't do us any much greater favor to be able to to do things in a way consistent with other provinces, which I think is in a way the kind of natural response we get in the discourse between provinces, territories, and the federal government, which is, basically, we've got it, mind your own business. But the problem with that is that the nobody's really asking citizens how they're benefiting or not from having the locus of control within provinces, but not interoperable with other parts of the country. And this tracks back to what Stephen was saying about connecting health data governance back to the Canada Health Act, which is that that Canadians move around a whole lot more than they used to, and that alone, I think, really raises the question about whether or not one of the 5 principles, which is about portability, is something that we're actually meeting in these times where we are moving around. We live in the digital world, and yet it's increasing. It can be very, very cumbersome to access health services in one jurisdiction to the next, and then also have some sort of record of what you've had happen from jurisdiction to the next. So from the standpoint of the individual person, Canadian citizen, for example, I'm not entirely sure that they find this a particularly efficient system themselves. We can say more about this later on about the person-centric approach, because I have some other things to say about that. But I think that I think it is massively inefficient the way we're running things, and I think that the kind of discourse that we have about whose job it is to do this is actually partly muddying the waters about whether or not this is effective or not, because we're not addressing the right questions here.
Yeah, the question more about who, rather than who's in charge, is does this benefit? Like, this, are Canadians being well served by this? I mean, I go on call on Friday in Yellowknife at the hospital. You know how we get CT scans to Edmonton, to our specialty services? We scan them on a disc and mail them.
Oh, you mail?
In 2025. Is that efficient? No, because they often get lost and so forth. These are for cancer patients, for whatever. So this is because there's really no mechanism between Alberta and the Northwest Territories to co-produce integrated technology, right? And and the other comment I would make about this, so what you're suggesting then, both of you, with the Canada Health Act, is that, enshrined in it are the 5 conditions, portability being one, and yet the information, and we all assume when we go to PEI or New Brunswick or BC or wherever we go that we are entitled to publicly funded health services, and yet the information we require to make informed decisions about that is not expected to be integrated. So that's what you're saying. This violates the spirit and intent of the Canada Health Act.
Yeah. And probably even beyond just portability, I think quality of care, right? Quality health and well-being of citizens. As we are moving into this age of digital health and AI, I can't see a more important pillar to quality and safety than data, making sure that it's managed well, that you have good quality, reliable data. And so I think it is. I do believe that it's the underlying factor is a lack of data literacy, because I think we've undergone a journey of many years of digitization and technology adoption, and there's been this assumption that that includes the data, that you've got good quality data, that it's interoperable. But at the end of many technology projects, people find that after investing all those millions of dollars, they don't actually have good quality data to work with. Like, you digitize your electronic, or you digitize your records, but you don't have the data that you thought you would out of the box. So it just takes a mindset shift, I think, in terms of the investment that has to go into governing and stewarding data well.
Excellent. So I'm going to turn to another question here, and there's lots of stuff coming in. I don't think as I said, I don't think we'll get through it all, but we can do more of this, and another one if people are interested. So, Bill C-72 was fairly sort of truncated legislation that really focused on unblocking. Someone asked, so what does this have to do with Indigenous data sovereignty and the potential to amplify it or be accountable to it or realize it? So I thought that would be an important matter to discuss.
Well, for sure, I think addressing the interoperability issues between systems. So C-72 is really focused on trying to put in place standards that haven't existed between different systems, so that you can actually share data between them or bring data together from different sources, right? So for sure, that would be an enabler of being able to identify and bring together data owned by Indigenous communities that they want to repatriate or have better control over, right? So it would definitely be an enabler and probably a sort of a condition precedent to actually doing some of the things that it means to enable data sovereignty.
David, do you have anything to add to that?
Yeah, I think that I'm just thinking this through. I sometimes hear interoperability and questions about data sovereignty being put together in a way that suggests that interoperability could potentially undermine data sovereignty. But I'm not sure if that was the intent of the question, but I have heard it sort of put this way before. And I don't personally think so. I think the objective here is to have interoperable standards and systems so that when you do want data to flow, it flows in a way which is effective. You're moving between trusted repositories. There's a model there for data stewardship, which means that there will be a permission structure about who can view what and use what kind of data. So interoperability is actually meant to be an enabler of effective imposition of access conditions on who gets to use which data. And so this is consistent. Like, there's a movement that many on this call will probably be aware of, but there's been a movement towards what's called FAIR data as opposed to open data. And the FAIR part is an acronym. It's findable, accessible, interoperable, and reusable. And the idea is that it's good to know where data sets exist. So that's the findability part of it. It's great if you're, say, working in the health space or another sector, that data is interoperable and reusable. But the access piece is not just like constantly free and open access. What it means is it can be conditional access. And that's really important for data sovereignty questions. But even when you're talking about sensitive data or identifying data, you need access conditions about how that data is shared and used. And so that's why I think that the kind of data standards that we need to reach for in the context of thinking about the Canadian system are those that actually are enablers of interoperability, but also sovereignty, where somebody wants to assert it, or where we have specific restrictions in mind because of sensitive or identifying data. So I think these things are meant to go together.
Excellent. And so I would add to that a concept that I learned from Gwen Phillips, who's a huge knowledge holder in this area. She's First Nations from BC. And she describes often, or has certainly to me, that sovereignty, we each as individuals have sovereignty over our data. And then there's an added layer, and whether this is shared by other Indigenous groups and peoples, I don't know. But then and hopefully I don't misrepresent this, but there's an added layer of community-based sovereignty by Indigenous nations that we need to honor, and which traditionally, as we're procuring technologies in Canada, really has often been absent and not noticed. And clearly there's a huge amount of good work from the FNIGC and Inuit and Métis peoples designing this, and it's not my expertise, but certainly I agree with you, David. If the data can't flow to the communities, peoples, nations that it belongs to, then it's hard to realize sovereignty if it can't get there. Mm-hmm. So we clearly need to design interoperability in a way that honors all the respective rights, inherent rights of Indigenous communities and each of us and that's, David, you mentioned person-centric data architecture at the beginning or a little while ago, and so that all needs to be honored. Mm-hmm. So I don't know if you guys have anything you want to say about that, but
well, I would say that certainly working with data, identifying data or any other kind of sensitive data is not news in health, for example. I think that thinking about Indigenous data sovereignty around health data is a newer a newer challenge to meet. But there are other contexts in which data which has arisen from Indigenous people does in fact have protections on it. So for example, you can draw inspiration from other contexts, like in biodiversity data, where there's a system called local context, which applies biocultural or traditional knowledge labels to biodiversity data and data sets, such that when somebody says, "Oh, this is a really interesting data set, I'd like to have access to it," that request for access puts up essentially a flag. There's a marker there associated with the metadata, and what that flag says is you have to ask for permission, right? So there are ways of actually building triggers into these systems about specific data or data sets and access, which we're already using, and this is another form of interoperability, because it's the data doesn't even necessarily in that case have to be all that interoperable. What's happening is from one database to another database or web-enabled query, it will actually generate, through an API, a subroutine that creates these notifications that go up, and and then that then leads you down the process of saying, oh yeah, well, this is good. Yeah, we need to contact that local community or that country or whatever it is to request the full permission, and then that process starts to look more like a data sharing agreement. It's kind of contractual, in which you agree to use data or limit your sharing of it, or whatever it happens to be, in ways that are respectful of the holders of that data. And to me, that sounds like data sovereignty. I mean, that sounds like control. And I think this stuff is all actually within reach. I'm not saying it's easy or cheap to put into place, but we're doing it in other contexts. We have done it to a certain extent with regular health data. So I'm quite confident we can achieve this with Indigenous communities and other communities in Canada.
And maybe each of us. And it leads me to a question here that Shelley Brown has asked. I would be interested in thoughts around data custodianship. So you mentioned custodianship before, David, and Stephen, you're working on a framework, a data sharing agreement. So we exist in Canada across all provinces and territories with really a legislative approach to health that is framed around this notion of custodianship. David, we talked about it in the third report of the Pan-Canadian Health Data Strategy, and we suggested that this is probably antiquated. It's an analog policy in a digital age, and it is successfully, not intentionally, but successfully leading to the fragmentation of individuals' health information. First of all, I don't even know if most people understand how that process, why a custodial model is leading to that. But Shelley Brown, and so it'd be interesting to articulate that. But she's just saying, she's interested in particularly a view to patients understanding their rights to their information and acting as a hub for their information. So I don't think Bill C-72 went there as such, but it does aim to address some of these issues with custodianship, if you guys want to talk about that.
Sure. Yeah, I think there's, as holders of health data, obviously, whether it's an institution or an independent, primary care physician, there's certain responsibilities that come with protecting that, right? So I think that's what historically the health privacy legislation has been focused on. And I think with respect to patients being able to get access to their data and see it in a consolidated way, the challenge is to have all those separate data custodians come together in a way with all the different systems that they have to, provide that, right?
And
so
Stephen, is there a mechanism for that now, currently?
Yeah, I mean, not currently, but I think we're working on things that could help. I think one of the big, again, I'm big on this mindset shift. Ever since coming out of the health authority and seeing things from outside a large health institution perspective, I think it's been really eye-opening to see, an institution's definition of what is patient-centric may be completely different than what a patient thinks, right? Because I like to say that whenever, especially with large, institutions, in health institutions, when there's a mandate to do something to serve patients in a better way, they spin up programs to try to solve that, right? So patient portals is an obvious solution, but if there's a myriad of patient portals that are developed by different organizations, health institutions, then a patient's data may be in all of those different portals, and they would have to get a dozen different logins, right? So that's not really patient centric. So I think we need to think about the overall picture. It's like, what is truly patient centric? It's an example is to give them the ability to pull their data using their chosen preferred health digital health app, right, that is catered to their specific health journey, and to be able to pull that data together, obviously with their direction, right? It's all consented, but that also means that all these institutions have to be more comfortable with relinquishing a degree of control over how that data is being used by the patients, right? And so there's a big culture shift that would actually have to happen, because a lot of clinicians are not comfortable with patients potentially having more information than they were used to, and also running it through ChatGPT and then asking them questions about it, right? So, but I think it's a reality that the health sector has to confront.
David.
Yeah, I think one of the other things that goes along with thinking about different ways of handling data apart from a custodian model, in addition to the fact that it is the law of the land that individuals own their health data, right? So that's established. But the things that Stephen was just alluding to, like the custodian model, has the implication that it's more a matter of storing and safeguarding the interests of the holders of the information, as opposed to making accessible that information to the people that it actually fundamentally belongs to, which are just the citizens. So then what are the alternatives? And I think that's where we look more towards other kinds of models around data stewardship, which is actually less of a custodial I own and control model, and more a matter of I as a data steward have a role in curating your information and then making it accessible and useful to you and to the broader health system. And that's a very different way of thinking about people's roles and responsibilities in the system.
Yeah, and do you think, David, that most Canadians know that this information is theirs, right? And do most providers know that it actually isn't theirs? So,
well, that's an empirical question. I haven't seen any really super recent data, but data in the past that I have seen suggests the answer is that no to both halves of that. But I don't suspect that there's much more than that to the story. But I'd be happy to be enlightened, because I think that the reaction to those sorts of questions would be one thing, but understanding the reasons behind it, why it is actually owned by citizens, and essentially merely, well, maybe not just merely stored, but administered, let's say, by other healthcare professionals and agencies, is why that should be the case, I think, is important. So
yeah, and there's a question that really points to this, and this is from I'm not sure who it's from. Do we risk legislating interoperability before healthcare providers have achieved interprofessional trust and digital maturity, or is regulation going to drive that cultural change? I think we require this legislation, but are we prepared for it? And fascinating question, speaking as a physician, because I've gone to many meetings over the years where physicians say, I'm not sure if I'm comfortable sharing my information. I just sort of sit there and so it's not yours. We're just holding it on behalf. It is not our information to decide. It's up to, as you've just said, David, it's up to Canadians legally, based on the Supreme Court of Canada decision in the early 90s, right? And yet, and I think Simon Higgins is on this. I saw his name somewhere here, but hello, Simon. But, under his tutelage, I did research, and I believe it was about 40% of Canadians in 2024 had access to some of their health information digitally. This is a third of a century after the Supreme Court of Canada said this belongs to us. So we clearly have the technology to do this, but there's something that the legislative construct has not promoted this, has it?
No. But to go back to the original question, which was, I think, about suppose we have this objective of having interoperable health data across the country that's readily accessible to the people who own it, which are individuals. How the question was more along the lines of, like, how do we actually get there? My view about this is that Bill C-72 was interesting because it raised the question in quite a concise way about the things that we're talking about, and avoiding one of the very notorious pitfalls, which is vendor lock-in effects, which is a real challenge. And I think that was good, but when you think about how it would actually play out in terms of provinces and territories starting to agree to find common ground for that would establish interoperability, I personally believe that the most effective route to get there would be to actually do the kinds of things that we are doing in networked health and with CIHI and other organizations, to raise awareness, to get this into, if not all the way into public discourse, at least we're doing things like webinars and talking to elected and unelected officials, speaking to professional groups about these issues. Because I think that once you start down this path of talking about it, it becomes, I think, blindingly obvious that we really should be doing this. And I think it would be much better if we could find a way to arrive at solutions where we do establish interoperability of health data, rather than have it just brute force regulated in. And to tell you the truth, I'm far less concerned about something like the reappearance of Bill C-72 or a version thereof, because I believe that it sets at least some ground rules about what the feds would expect in terms of Canada Health Transfer. That's really the sort of thing that it does. A federal bill like that applies conditionality to the processes and the that establish the health transfers and the conditionality of that money. Where I'd be really concerned about possibly generating retrograde motion or just zero progress on this at all is if we end up having legislation just sort of brute force introduced in provinces where it puts the province on with a collision course with the various colleges of physicians and other healthcare providers, because I think the realpolitik of this is that provinces occasionally go to battle with teachers and usually lose. If they go to battle with healthcare providers, they will most certainly lose, because it's very difficult for provinces to actually affect legislative change. And they have to do it carefully and incrementally with healthcare providers, because they're a very powerful group. So if the provinces tend to lose with teachers, the more powerful groups are actually healthcare professionals. And that's why I think you see a lot of provinces go into thinking about electronic health records and stuff like that with with some trepidation and in a way that's very circumspect, because they know that they can't have a big mess blowing up on their hands. So that's why I think that, the sort of moral suasion backed by some high level governance and some also some high level legislation is probably the way to go in this, if I were to pick a path. But that's my own personal view about how things get done.
I would add, there's another thing we need to do, and I'm speaking as a clinician, as a physician, and that is understanding that this dialogue, and Stephen, we'll get to you about trust here, because we're talking all about trust, and this is your domain, but I just want to make one comment. This individual talks, are providers ready? Is it that we're going to feel uncomfortable about sharing the information that we are the custodians of or that we manage? We are burning out because of fragmented systems. It is just, so the quite one thing is maybe our reluctance to share, oh my God, are patients ready, and this and that. Maybe it's a little paternalistic, but this is what is reflected in that a little bit. But I think there's a lot of good intent there. But our research shows the degree of, and much research but we're coming out with a paper soon on health data related harm that shows, and we partnered with Mount Sinai Hospital in New York City on this, that burnout or a lack of well-being on the part of health providers is a huge issue that is being propagated by a lack of health data interoperability, lack of access to information. You can't make informed choices. You're frustrating navigating all these different systems. So and there are other issues happening as well. So there's all kinds of compelling reasons, well beyond comfort around the sharing of information, that can benefit us providers and help us do a better job. And similarly for health regulators, for the professional regulators, if we, and I work part-time at a regulator, if we're supposed to be upholding public protection and public good and quality of care through our members, by regulating our members, then we have to assure that they have access to the information they need in order to do a competent and safe job. And this is often a place that people haven't gone. So I would suggest that providers can learn a lot about the negative impacts of a lack of interoperability on our ability to perform our jobs. So Stephen, this question also implies issues of trust. You're working on this trust framework. Trust between provinces and territories, trust between professionals and patients and government and custodians and different professionals and so forth. I mean, seems to be a transcendent problem in Canada. Your thoughts on that?
Yeah, maybe I'll just comment on what you and David has said. I think that I totally agree with David around not trying to brute force things. I think C-72 does actually do a number of things besides just sort of on the face of it, right? In terms of the technology interoperability, I think it's the first time that we've seen sort of like very at the highest level, at the federal level, that this is so interoperability and data sharing so important that we're willing to legislate it, right? If parties aren't going to do it themselves. So I think that's an important tone to set. But I do agree that unless you have the stakeholders bought in and see sort of mutual interests in doing these things, then it's going to be hard to actually see change on the ground, and it'll be painful, right? So I came up with this term where I like to call this like data diplomacy, right? Because it is sort of the politics around data, and you're basically like doing trade deals around data, and so I think that's the way that we have to view it, because data is sensitive, whether from a patient perspective or even from an organizational perspective, right? Because it can tell a lot, or potentially tell a lot about an organization. So that's why organizations are protective of their data as well. So I think the way to overcome that is to actually invest in good data governance and stewardship, to actually have structured, facilitated conversations about this, because everybody's super busy in the health sector. Leaders are primarily focused on care delivery and long wait times in hospitals and all these other things. Unless you make it easy to engage in these conversations, they're just not really going to happen, right? And somehow you have to find those mutual interests amongst the different parties from many different perspectives, not just addressing privacy and security, but how does it impact, resource decision making? Does it impact, how certain programs are assessed in terms of performance, that type of thing, right? So yes, the trust framework. So the federal agencies, Infoway, CIHI, are really leading initiatives to kind of create more trust within the health sector. And so there is a framework evolving called the Common Agreement for Health Data Sharing, or the NISA, the National Health Information Sharing Agreement, that Infoway is leading, and our team at Inc. is helping with that effort, working in conjunction with also CIHI and the data stewardship work that they've done. So it's really, and also I'll mention that PHAC, Public Health Agency of Canada, has also developed a public health information sharing agreement that's really advances the data governance in the public health domain. So now we're trying to bring those initiatives together in a cohesive way, and trying to bring the federal agencies as well as all the provinces and territories together, so that we have this sort of more coordinated approach. So think of it as really a nation building project, right? Because historically we talk about infrastructure projects, right? Nation building infrastructure, and it's like highways and buildings, and even in the technology realm we talk about technology infrastructure, hardware, right? But I think we need to invest in what I'll call relationship infrastructure, right? It's establishing these relationships between the different parties based on the various trust factors that we need to have in place in order for them to be comfortable with sharing with each other. Like, what are the rules of the game, right? With respect to privacy, security, ethics, how are you going to use this data? Are you going to report, are you going to generate reports about my program that you don't understand? All of those issues need to be addressed in order for parties to actually really, want to or willing to share the data. And also the education, I think the awareness about how there are harms arising from the lack of interoperability. I think that is often unknown because we often work in our own sort of worlds, because even that is sometimes demanding. So I think all of these discussions, I think, are really helpful, and the more that we can raise awareness to more people in the health sector, the better.
Yeah, I agree with that, and I'll just say one other thing about it, Stephen, is that the idea of having something like almost like trust infrastructure or trust architecture is absolutely important, and by sort of casting it in that light, it means it really is a strategic question, because you have to know where you want to go with this in order for you to actually set out the boundary conditions that generate that kind of trust. So in that respect, I don't think it's at all far-fetched to describe this as a kind of a nation-building exercise, in the sense that we don't have something now. It's glaringly obvious that we need it. Bill C-72 raised some of the questions around what we actually do need. We are not using to the fullest this opportunity to go back and think about what the Canada Health Act means in a digital era. So I think that's a national conversation that's required as well. And I think that once we start to get further down the road of thinking about what our strategic priorities are for health data in Canada, then we can actually, I think that you do lay the groundwork for actually generating trust between organizations and people, because at least we would have some overall sense of what we're trying to achieve and what the objective is and what the benefits are. And in this space too, what's interesting about this is that having worked with you and others on this for a number of years now, what's really interesting is that this whole problem about interoperability of data is, as a problem, kind of immune to being rendered in zero-sum game kind of language, because there's actually next to no compromise or downside in doing this. So it's not like you're actually saying, well, if there are going to be some people who win in this, there's definitely going to have to be others that lose. I think that this is an interesting public policy question, where it's actually all upsides, and technical things that need to be addressed around privacy and sovereignty, and those sorts of things are minor operational matters. This is not like you end up with winners and losers out of this, or at least I in all of the discussion we've had, everything we've written about this, what makes this actually really intriguing to people is that it's like, yeah, actually, if we did this, it would be better for everybody.
And that doesn't always happen, does it, David? And in fact, and that's a very, we just have a few minutes left here, but it's a very, very powerful message. At the end of Interoperability Saves Lives, we did that analysis. So who in Canada is going to suffer from interoperability? There is doubtless going to have to be a lot of work to achieve this. It's going to take a long time. Legislative, regulatory, cultural change, our literacy, our perceptions, our relationships, all of that, trust. But in the end, achieving it, so we did an analysis. We looked at professional groups, governments, patients, right? All the community-based services. And by the way, I tip my hat to Sandra Keller. Yes, when we talk about providers, and George Alvarez, if he's here, will say it's all people providing health service, not just health professions. So absolutely, it's part of the continuum of a patient's care team. So, our analysis was like, no one, exactly as you said, no one's going to suffer. But as Stephen just said, there's a literacy deficit in understanding that we need to help promote a dialogue, all of us together, that actually we can be better as a nation. So this notion of relationship infrastructure, David, I think is what you just said. It's a really cool term. I never heard of. So as a nation building effort, right? So we're talking about nation building, we're talking about these infrastructure projects, but this can be a relational project in Canada that really is obstructing our capacity to achieve interoperability at this point in time.
Well, I would actually make one request of all of our audience here, because I think that I'm sure that there must be somebody who's learned in this space, and I don't know about these sorts of things, but I do notice that when I talk to people in other jurisdictions about health data and the challenges that we encounter in Canada, one of the things that gets disclosed very quickly is that they just also have a different sense of their relationship as a citizen to the state than we do, and the expectations around access to information and government responsiveness. And I'm thinking here in terms of countries where people have citizen mailboxes, electronic mailboxes, like Denmark, countries like Estonia that have citizen cards of different kinds for different purposes, where they have access to information, and they just have a different set of expectations about what the state actually ought to be and can be expected to deliver to them. And I'd be really interested if anybody wants to get in touch with us, if there's some people who understand those relationships and how digital technology enables them, because I think that's part of the cultural story about Canada, and some of why we actually have little awareness and some slowness and uptake of health data interoperability, is that there's some other things about the way that we talk and think about citizenship and government in this country, which is different than other places. So if anybody knows more about this, I'd be grateful to receive some.
Fascinating. So we have like a minute left. I'm just going to make some closing statements here. So thank you all. We got to like 3% of the questions, and I apologize, but I really appreciate David and Stephen. The whole focus of Network Health is to try to raise this dialogue in Canada for, frankly, reasons of nation building. We believe that the manner in which we use health data can be improved to benefit us all. That's our notion. But we want a safe, free, open space for these dialogues. There's a lot of excellent work going on in this country on the part of pan-Canadian health organizations, patient advocacy groups, academics, technology, vendors, on and on and on. And we aim to bring everyone together, and I've forgot community-based services, whatever, you gotta list them all, to help even lawyers like Stephen. So I just teased Stephen there. So you know, we're better together, and raising the profile of these issues is important. So for those of you who haven't gone to our Renew 72, and Bill C-72 is far from perfect, but we perceive it as a first step in a long journey. And it won't be Bill C-72, it will have to be renamed, but we need to reintroduce interoperability legislation. And so if you support this, go to our website and sign in, or sign your organization in. And the last thing I will say is we will have forthcoming webinars on some work coming. We are validating our harm framework with the Mount Sinai Hospital. There is all kinds of cool findings that inform this whole discussion. So this is coming soon to a webinar near you. So thank you very kindly, and sorry to all those we couldn't answer all the questions.
Thank you.
Thanks.